Our final TED Talk is by Peter Pronovost, who is the UH Chief Clinical Transformation Officer and Clinical Professor of Anesthesiology and Critical Care Medicine. Sounds like a doc. But he was named the MacArthur Genius in 2008, a title that I think you get to keep for a while. His career is studded with incredible research and evidence-based practice-changing observations, things that most of us want to accomplish once in our lifetime. He does very commonly, about critical care, medical complications, and improvements in population health. A hallmark of this effort, which I hope he talks about a little bit today, is the simple concept of a checklist designed to reduce the variability in what we do in medical care, improve efficiency, the critical areas of consistency, so that we can always practice at the top of our game. Before his position at UH, Dr. Pronovost was at Johns Hopkins Medicine as a Senior Vice President and Founding Director of the Armstrong Institute for Patient Safety and Quality. He's a member of the National Academy of Medicine and was recently named to co-lead the HHS Health Quality Roadmap Initiative that will instruct national efforts in healthcare quality and safety. His topic is From Healing to Hospitals and Hospitals to Healthy at Home, a New Narrative. Let me make sure I pull up. Here we go.
Thank you all for spending some time with us today. The kind of work that I'm going to discuss is called implementation science. It differs from traditional science because traditional science is generally, is Coke better than Pepsi, feed forward. This starts at the end and works backwards. As beautiful talk before this, implementation science is the man in the arena. It's trying to change practice in the real world with all its majesty and messiness. Now, I'd like you to write the words "I will" down, or think about the words "I will." Because you see, you do miracles every day, and I have the privilege of working with Drs. DeLimo and Technos and seeing things like CAR T therapy being done in a highly cost-effective way, changing people's lives, and it's breathtaking. But yet, medicine today has medical error at least the third leading cause of death. And if we add misdiagnosis, which we're learning is increasingly common in cancer, if we add not treating blood pressure or COPD, it is by far the leading cause of death. A cause of death that we don't need to wait for a cure. We are the cure. We just perhaps don't know it. Medicine today, even though we're improving our experience scores, leaves somewhere between 2 and 4 in 10 patients leaving their interaction with their healthcare provider feeling, I wasn't respected, I wasn't listened to, and I'm scared when I leave because I don't know what to do. And medicine today squanders a third of every dollar we spend on therapies that don't get people well. Nationally, it's $1 trillion, almost mind-boggling to think about. But locally, it's $10,000 per household. That's more than the median net worth of the people we live around here. And if you look at every payer of healthcare, the federal government, state government, local municipalities, employers, and us as individuals with high deductible plans, our healthcare costs are going up more than our revenues. And that's not a sustainable model. So all the states that have expanded coverage, and I believe we need to give coverage, have done so at the expense of every other social service. They cut parks, they cut preschool, they cut STEM. So my friends, getting this healthcare value thing right isn't just healthcare, it's the future of the American dream. I think about your own work, our work in cancer, and if we did all the things that we knew we could do, from immunizing people and diagnosing accurately, treating timely, treating accurately, and giving appropriate follow-up, what % of those 600,000 cancer deaths can go away? Maybe a paper for us to work on, because I think it's enormous. I've never seen it modeled, but it's enormous. So what's holding us back? Well, the policymakers think we all are just economics beings, that if we change how we're paid, you take a nickel of your pay or give you an extra nickel, we're going to solve this problem. And though we need to align incentives, my friends, that's not alone the solution. The solution is something deeper and much more human. It's the stories we tell. You see, stories are the most potent force for change in the world because they define how you act. Whether you see yourself as powerful or powerless, whether you see your colleagues as competitors or collaborators, including the different institutions in this room. And Stan, great job of building that collaboration. You change the narrative and you change everything. Narratives like JFK, nonviolent protest, or JFK, I want a man on the moon, Martin Luther King, nonviolent protest. We have a narrative in healthcare that still says success is having people heal in hospital. And my friends, that's breaking the bank. Success is having people healthy at home. And today we're going to explore what it needs to craft those narratives. You see, there's 3 sub-narratives that I believe that are holding us back and that we're seeking to change, at least in our health system at UH. First narrative is stop believing that harm is inevitable and start believing that harm is preventable. My own work, as Stan alluded to, began in 2001 on a snowy night in a dark corner of the pediatric ICU when an adorable little 18-month-old girl, Josie King, who looked hauntingly like my own daughter, was taken off of life support and died in her mother's arms. She had been burned but was healing, was actually supposed to go home that day, but a catheter infection sacrificed her, which they're also a big problem in cancer patients. At the time, catheter infections killed more people than breast or prostate cancer. Think about that for a second. Breast or prostate cancer, and we just accepted it as the cost of caring for sick people. We thought that sometimes when you care for sick people, little girls like Josie will die, and she did. Her mother came to me and said, "Peter, what are you going to do about it?" And in that moment, I knew we needed a new narrative. So we declared a goal of 0 infections, implementation science stuff. And my colleagues thought I was smoking dope or something because saying, hey, we're a great institution, we care for sick people. I said, yeah, but we're not doing what the evidence says you do. We will be 0. We made a checklist, really simple, of best practices and made it easy to comply. We empowered nurses to stop doctors if they weren't using the checklist, highlighting the importance of culture and literally causing World War III in the process. We created accountability systems where leaders had to review infection data and make sure there was a plan if the infections were high. And then we spread that program state by state. Today, those infections that used to kill more people than breast or prostate cancer are down 90% in the country, 9-0. The tricky thing is, we cured a problem the size of breast cancer, but the solution was in every clinician. They just didn't know it. So we partnered with some anthropologists and sociologists and said, what happened with this? Because if we could understand it in a mechanism, we could have a really potent force for change. Turns out the social science literature is quite replete of what leads to large-scale change like that. It's 2 simple things: believing and belonging. Believing that you could achieve 0 when so many of us have self-doubts. And the best example of that is Roger Bannister breaking the 4-minute mile. As you may know, for 2,000 years, leading scientists, including some at all of our institutions, said it was physiologically impossible to break the 4-minute mile. You will die trying. Well, he didn't die. He broke it in 1954, and you may know that. What's often not known is the next year, 12 people broke that impossible record. The year after, 156 people broke it. And now high school kids in Ohio in the last New York City Marathon ran 4-minute mile for the whole 26 miles. So what changed? Not evolution or doping, their belief. Bannister freed everyone up to break that 4-minute impossibility. And my friends, that's what we need to do for defects in care. The second part of changing narratives is belonging to a peer learning community. Not judging, but belonging. The best example of that is from Mary Poppins. And how many of you have seen the movie or the play? And you probably recognize that a very prominent feature throughout the play is these birds chirping. And that's because in the 1940s, London was full of 2 types of melodious songbirds, the red robins and the blue boobies. And they thrived in downtown London because they used to peck through the tops of the milk containers that were left on people's stoops. They sucked the fat out, and they were chubby, happy, well-fed birds that were singing their hearts out. But then the milk companies changed the tops from cardboard and steeple to aluminum and flat. And both birds were equally smart. And a few of both birds learned a new pecking technique. They had to tuck their beaks more. But the red robins are extinct now, and the bluebirds thrive. The only difference is the red robins were solitary birds. They had their stoop or their corner. We call it our department, our discipline, our institution, and that wisdom never disseminated. The bluebirds are flocking birds. They fly strong and proud together, and that wisdom quickly disseminated. And if I think about the wisdom to solve these defects in care that are happening, just between our own institutions, I guarantee you someone in some place is doing some best practices that if we can call it out, would save lives right now. The question is, do we have the structures and the culture to allow us to be those blue boobies? Second narrative, stop believing that value's not my responsibility. Start believing it's all of our responsibility. I've been working a lot with Dr. Technos on some of this and some brilliant stuff where we're looking at defects in care and guidelines for breast cancer in this case. And all of the guidelines start from their own discipline, rad-onc, med-onc, surgery. But if you're a woman with cancer, time is suffering. And we said, are there any national standards for time gates from when I feel a mass to when I get this done? And I know that the clinic's done some great work in that. There's no national standards. But if we organize care around patients, there would be. Or our readmission rates for cancer patients with symptoms or sickle cell patients that Marcos and I were spending a lot of time on. Who owns those defects? The reality is nobody does right now because we're not working as a system. You see, a system is a set of parts interacting to achieve a goal. All of our organizations have either bought or built the parts, but we're not aligned around a goal. And we certainly haven't hardwired those connections. But the patients expect us to. We have defects in helping people stay well, that is giving all the immunizations and preventive care. Defects in helping people get well, that for any chronic disease, could we say it's diagnosed? They're on the right therapy. Their symptoms are controlled, so we're titrating that therapy or addressing social determinants, and we've avoided needless hospitalizations. Take diabetes, 40% undiagnosed. Half on the right therapy. 13% have their A1C, lipids, and blood pressure controlled, and 95% have avoidable hospitalizations. All preventable, but those defects are invisible, and we don't own it. Not yet. And then defects in managing an acute condition, saying is care coordinated with their primary care or oncologist? Is what we're doing appropriate? As you know, the only benefit why we have these centers of excellence from the employer view is they don't cut 30% of the time. Because we know almost every procedure that we looked at, 30% of procedures are inappropriate. They don't have guidelines. We know centers of excellence don't do that. And the oncology center of excellence, that's being too glib. That they give much better medical care. But for the joints and the hip replacements for bariatric surgery, that's what they're buying. Are we giving care in the highest value site of service? We know 40% of care could be given in a lower cost, equal or high quality setting, but we don't do that. And are we referring to a high value provider, in this case a comprehensive cancer center, overwhelming data that we give better care at those comprehensive cancer centers? But we don't work as a system. When we look at what it takes to work as a system, I learned some of this from visiting an aircraft carrier. They're the prototype of a high reliability system. That is, they eliminate defects. And I was speaking to the admiral on the flight deck, and to be truthful, complaining about how hard it is with residents. And he says, Sonny, let me tell you my world. We're out in the middle of the ocean on a ship the size of a football field. We're pitching in 60-foot waves at 30 degrees, and we land a plane with enough bombs every 3 seconds, and it goes off flawlessly. Stop whining and start leading. Get it? And standing next to the guy was a gentleman sweeping the deck. And on the power hierarchy, as you know, that guy's way below the admiral. Just like the people who clean the hospital rooms are way below the CEO or the president of an institute. But on the safety hierarchy, they're equal, because if there's a hammer or debris, plane hits it, they all blow up. I asked that gentleman what job he did, and I was blown away. He stopped what he was doing. He stood up tall and proud. He looked me in the eye and said, "Sir, I help planes take off and land safely to serve the mission of the United States." I said, wow, that is a person connected to purpose. And he kills people. I then left that and went into healthcare, and we saved lives, and asked a housekeeper, person who cleans the rooms, what job do you do? And what answer do you think I got? I didn't get standing up tall and proud. I got someone turning away shamefully and said, I clean the rooms. I said, no, 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 you prevent infections. You are a healer. I asked a person answering a call, what do? I answer the phones. I said, no, you don't answer the phones. What you do is you comfort people. You connect people to the care they did. And if we're going to be eliminating these defects in value, it will require every member of our organization, when you ask them what job they do, to answer affirmatively, I save lives, or I heal, or I add value. And we empower people to act on it. We just did this amazing experiment with this, where getting people into transplant with ESRD is a really important thing. One of our nephrologists said, hey, you know, Peter, our dialysis techs spend 2 or 3 hours a day with patients, and they just talk to them. They trust them, but we never scripted the conversation to see if they could help convince people to get transplant. There's a big barrier that people just don't get referred. So she trained the nephrologist had a script, the techs had a script, referrals up 45%. Why? Because they empowered a person who's with these people who were never thought as part of the care team. Third narrative, and perhaps the most important, is stop believing that financial incentives alone will solve this problem, and start believing that the secret of high quality care is love. And by love, I don't mean a 50-year marriage, though there's love in a 50-year marriage. By love, I mean what the psychologist Barbara Friedrichsen writes about. She studies the biology of love, literally what makes oxytocin spike. You know, oxytocin is the cuddle hormone, and found that oxytocin spikes, love occurs in micro moments of connection between two people. Micro moments. The idea is, I feel warm towards you, you feel warm towards me, and we create energy. And if you ask any clinician or any person, what are the most memorable events in your career? It's not some, great diagnostic dilemma that you solved or some outrageous surgery. It's a micro moment, almost guaranteed. It's some very intimate moment. Because you see, this big change that we're embarking on is the sum of hundreds of small ones. And every one of those is facilitated by micro moments. Change progresses at the speed of trust. And trust grows when we do things with others rather than to them through these micro moments. And that's our research collaborations, where we bring disciplines together or institutions together and work together to solve problems. And the beauty of these micro moments is they're contagious. I don't know if any of you are familiar with some of the literature. It's a lot of it, primarily Nick Christakis, who studies these social movements, and found that if you put a fit person on a team, not only is everyone on their team more likely to be fit, but 3 networks out. The dose effect goes down, but it's still there. Same thing though, you put a jerk on a team and you sour the rest of the rings out, but you put someone who creates micro moments and you create a virtuous cycle. I learned about this in an unlikely place in Dunkin' Donuts. See, I'm an intensive care physician, and on Sunday mornings, it's probably like many of you oncologists, we would bring bagels or donuts for staff for Sunday morning rounds. And we used to stop by the Dunkin' Donuts in Baltimore that was around the corner from the bail bonds and a block away from the homeless shelter. And so Dunkin' Donuts on any Sunday morning was kind of half homeless people, half people going about their jobs in the morning. And in front of me was a homeless couple, and it was February, just before Valentine's Day, and they were seeing if they had enough change to buy the heart-shaped donut with pink frosting that's commonly released by Dunkin' Donuts at that time. Some of us may have had that before. And they were a nickel short. And the woman said, oh, could you get us a nickel? And I was feeling guilty about buying food for most of the people who probably didn't need it. and yet these was probably their only meal for the day. And I said, you know, I'm getting an order. Just go ahead and order your food. And so they go up and order, and the cashier must have thought they were going to be stiffed or had unconscious bias or maybe conscious bias. Said, you can't order that food. You don't have any money. And the guy made a scene and said, no, the guy behind me is buying me breakfast. And I said, yes, I'll buy them breakfast. They can get whatever they want. Well, there was a nurse standing next to me who said, what a cool idea, and turned to the homeless person next to her and said, could I buy you breakfast? There was a cop on the other side of me who said, could I buy you breakfast? There's a Sunday school teacher behind me, and literally this love cascade went 7 people deep within 30 seconds, blown away. And I was walking out, and the couple said, can we speak with you for a minute? And I said, sure. And the guy said, you know, we're not nobodies. We just made some bad decisions in our life. And I said, yeah, you and all of us. But he said, we're going to get our act together. And I said, I believe so much you will. Do me a favor. When you do, buy somebody else breakfast. So fast forward to June, schlepping in there on a Sunday morning, buying bagels, and the cashier says, hey, Doc, somebody left this note for you, and written in a little crinkled piece of paper was, I bought somebody breakfast. So my friends, I hope you reflect on your I will statement, because right now, the degree of preventable harm and needless suffering and costs is unacceptable. And what's holding us back is simply the stories and the narratives that you tell yourself. So let's tell some new ones. I thank you.